We are ready. Finally.
So good afternoon. I am pleased to welcome you to the European Parliament.
Ακούτε, είμαστε ok.
Ναι, μια
The
χαρά.
Senior Area Affairs Manager at the European Cancer Patient Coalition, and I will be your moderator today when we talk about opportunities, threats, and policy implications when integrating digital health technology in cancer care. So please stay with us during the next 2 hours or so, whether you are here in person or online, and I'm sure this will be worth your time today. Well, Europe is living a digital momentum now with the European Health Data Space Regulation in the pipe, and EPP is leading on this dossier. And one of the main objectives of this regulation is to support the use of health data for better healthcare delivery, for better research, but also for better innovation and policy making. But to achieve such an ambitious objective, we need that both clinicians and patients adopt new technical skills so that digital medicine, along with the traditional clinical methods, lead to person-centered and effective care and treatment based on personalized needs and requirements of patients. So let's see how we can make this happen. I am pleased to welcome today MEP Stavrour from Cyprus. Welcome. Unfortunately, our host, MEP Stelios Kimporoulopoulou, could not be here with us today due to some health constraints. We wish him a speedy recovery, and I am pleased to share with you his message. Honorable panelists, dear participants and online guests, I am happy to host this event about integrating digital health technologies in cancer care, opportunities, threats, and policy implications. But unfortunately, due to a health issue, I couldn't be in person with you in cooperation with LifeChamps Consortium. In recent years, we have observed an exponential increase in the development of digital tools that have entered the medical space and transformed the process of clinical decision-making from early detection and diagnosis to selected treatment options, monitoring therapy, and evaluating its outcomes. The impact of these innovative approaches is especially visible in the fields of radiology and pathology, where computer-based tools acquire approval from the main regulatory agencies. Despite these undisputable advancements, broader adoption of digitalization in oncology is still relatively low given the amount of investments and potential benefits. Opportunities for digital health innovation in oncology include patient-facing technologies that improve patient experience, safety, and patient-clinician interactions. Clinician-facing technologies that improve their ability to diagnose pathology and predict adverse events, and quality of care and research infrastructure to improve clinical workflow, documentation, decision support, and clinical trial monitoring. Moreover, we need to remember that the pandemic COVID-19 dramatically disrupted the access to healthcare, particularly for vulnerable people. Among them, people suffering from cancer. That is why we should enhance more innovative digital tools and approaches in the field of oncology to help systemize knowledge about current developments and their potential medical applications. A special focus should be given to the advances in digital platforms supporting early diagnosis, response prediction, and patient stratification. Finally, I would like to congratulate you for your research and efforts as a consortium under the European funding program Horizon 2020. Your outcomes are an added value for the cancer patients community and healthcare systems. I hope you will have a fruitful discussion. Thank you very much. That was the message of MEP Stelios Kimporoulopoulou. I am now pleased to welcome, hopefully he can hear us, Professor Panos Vamidis, the coordinator of LifeChamps project, who is online, and would like to welcome you at this event and make some introductory remarks. Professor Vamidis, do you hear us?
Hello, yes, I can hear you. I hope you can hear me.
Yes, we can hear you.
Despite the background noise. Can speak it too.
We cannot see you though.
Now we can see you.
Okay. Thank you very much for hosting the event. Not being able to be with you there physically, but it's important that we are here virtually. I'd like to say a couple of words about the LifeChamps project and its instance now as the final event at the European Parliament and the support that we have from Dr. Timburopoulos as a member of the European Parliament. We thank a lot for his whole support and wish him all the very best in this period. The LifeChamps project has been running for quite some time. It's a project enforcing actually the digitization of healthcare and the fact that we deal with patients with cancer is a double challenge for us. It's a double challenge because we are trying to empower them with digital technology, but at the same time, it's a challenge because we're not afraid of thinking. We are trying to involve technologies that we will hear later on that embrace a number of difficulties. The worst of that being that the fact that people have to be wearing or being supported by these medical devices that digital devices for a number of days, for a number of months, so that we can try and collect as much data as possibly achievable from them during the therapies that they are undergoing. That's a challenge, but that's the only way to information to do what the therapy does for them and collect useful information. LifeChamps project has an effort to collect into an intelligent platform as much as of this data we can possibly collect and try to empower both the patients and the relatives, but also the clinicians with knowledge transfer. To this end, artificial intelligence algorithms are now hand collaborating with the hardware that we have got and the data that we have collected in a way what you might be hopefully for the patients, for the families, but also for the clinicians. With these words, I'd like to share with you guidance for this event. Please participate the very next hour. Thank you and good luck.
Thank you very much, Professor Bamidis. We are really sorry that you couldn't join us in person at the European Parliament today, but we are happy that we could hear you at least and we could welcome us at this event.
We can hear you.
Maybe we can. I represent the European Cancer Patient Coalition, and we are also a partner in the LifeChamps project. And in this sense, please allow me to say a few words about the policy implication of the project. Of this project. We all know that digitalization is a fast developing trend that has already a profound impact on all aspects of our societies, and harnessing the digital transformation has been actually one of the 6 high-level priorities of the European Commission during the current mandate. And this priority, that was very nicely entitled the Europe Fit for the Digital Age, was aimed to make sure that the transformation works for people and the economy, but is also closely linked to the green transition towards the climate neutral Europe by 2050, according to the Green Deal. Yeah? Health is definitely an area where you can benefit from the data revolution while increasing the quality of patient-centered healthcare, and Europe can own this digital momentum, can own this digital transformation and set the global standards when it comes to technological development. But it must do so while ensuring the inclusion, the empowerment, and the respect of every citizen within the healthcare system. And while digitalization holds many promises for new patients and healthcare systems, it is very important that EU institutions and the member states actually work together to foster patient-centered development of the digital health, with equity of access, with patient safety, and also with the quality of care as key pillars. And well, digital tools should start from the needs of the healthcare users and be developed with the users in order to ensure that technology actually facilitates a person-centered healthcare and leads to better outcomes for patients and better value for the society itself. And digitalization needs to be integrated as part of the national and European strategies to tackle health inequalities and avoid creating a new digital divide. And the EU Beating Cancer Plan that was published in 2021 reinforces the idea that cancer care is one of the major disease areas that will benefit from the European digital strategy. And through its proposed measures and flagship initiatives, the plan actually seeks to make the most of the potential of data and digitalization. And at the same time, the European Health Data Space that I've mentioned before is aimed to enable cancer patients to securely access and share their health data in an integrated format and in an electronic health records between healthcare providers and across borders in the EU. And innovation in digital health technology would definitely benefit the over 20 million of cancer survivors in Europe by improving, first of all, their quality of life. And in this sense, the LifeChamps project brings incredible added value because it aims to implement the ambitions and objectives of the plan in this regard by supporting and delivering the highest after treatment care, prevention and advice mechanism to all the cancer patients, their caregivers and clinicians by making use of emerging developments in the fields of big data, data analytics and artificial intelligence. And the research in this project put the needs, the preferences, the goals of the cancer patients and survivors from different EU regions at its core and successfully created a platform that is smart, that is personalized to a patient life environment and secure in order to monitor the health outcomes and address comorbidities of older cancer survivors by preventing long-term side effects and improving their quality of life. And the project definitely delivers a novel framework for quality of life, support to cancer patients and survivors. So yes, the outcomes of this project are an important step forward in patient-centered digital health technology development. But more about the outcomes of this project will tell you those who know best about this, namely Antonis Bilis, that is the scientific coordinator of the project from Aristotle University of Thessaloniki. Panos Karsidis, also a researcher at Aristotle University of Thessaloniki. They are here in the room with us today. We also have online Ioannis Mavrodopoulos, that is also a researcher at the University of Thessaloniki, and Vania Sofia Santos Tavares, a researcher at Capgemini. Thank you all. I give the floor to Antonis.
Thank you. Okay, so you're all seeing my screen. Thank you for being here. There were people who kindly come here and join us face to face, but also people who are online and accepted our invitation. So I'm going to give you an overview about the LifeChamps project. I'm the scientific coordinator. I'm representing the Aristotle University of Thessaloniki, who is leading a consortium of 15 partners across Europe. Among them, academia, industry, large industry, SMEs, novel SMEs and startups, but also representatives from the patient side. So all this consortium are working towards the main objective of this project 3.5 years now, which is to support the quality of life of older cancer survivors with a focus on breast, prostate, and skin cancer after their treatment, using novel technologies like AI and big data. So a key demographic issue that we all face around the world, but also in Europe, is the aging population. And with aging, we cannot we see that there is obvious increase also in cancer incidences. Around 50% of the new cancer incidences yearly are people that are more than 65 years old. Almost 6.7 million new cancer cases worldwide in adults aged 65 years old and more. And this, of course, has also an impact in terms of budget when it comes to healthcare expenditure. And here you can see that almost 20,000 million euros are being spent for cancer treatment that have to do with cancer comorbidities, which, as you all know, it comes also with age. But although the big pain we see here, there is still some space in terms of how the healthcare systems tackle this challenge, meaning that as in many other aspects in the healthcare, we are still seeing that there is ageism. I mean, the way that this specific part of the cancer population is being treated is really suffering from the problem of inequitable access to new treatments, and also it doesn't really take into account their needs and their preferences when it comes to care after the treatment or during their treatment. And of course, there are still gaps in terms of knowledge of how the treatment is interacting with frailty that comes with older age, and how these two combined affect the quality of life of cancer survivors after their treatment. So in LifeChamps, what we are trying to achieve is to combine novel data sources, heterogeneous data sources that come from the patient side, but also from the clinical side. So new sensors, mobile apps, and electronic health records are being combined using big data technologies in order to build machine learning and AI models that could identify these complex interactions that I mentioned before, and trying to create some phenotypes of patients and categorization of patients with some specific phenotypes that could provide some personalized care after their treatment through a mobile app for their education, but also an analytics dashboard for healthcare professionals who wish to personalize the care plan that they provide and the follow-up that they provide to these patients. So what kind of data are we using? What are the novel sources of real-world data that we are trying to collect through the LifeChamps project? So these include several sensors like smartwatches or activity trackers, as you all know, smart textiles, trying to gather more detailed information about vital signs of patients, also their behavioral profiles like their sleeps, their exercise habits, but also some other data sources like weight scales that can identify the body composition of these patients, especially when we're talking about frailty. It is important that we try to continuously track the body composition of these people, their body mass index, etc. But also some smart home sensors that they can collect, they can track the daily activities of these people, and probably I understand in an unobtrusive way their functional status. Similarly, we use smart plugs, which can track habits that are very obvious in the older age, like sedentary activities like TV watching, etc., which can be highly interlinked with some early signs or symptoms of the health deterioration, but also some questionnaires and some online sources that could be used as a way to understand the exposure to environmental stressors, like, for example, the UV radiation. So this data can be used in order to find correlations with clinical, some clinical data. For example, we are trying to combine here the different information that comes from daily activities of daily living, but also different patterns of activities, and trying to link them and associate them with different quality of life domains like depression or cognitive decline, which are some of the aspects that are being concerned when we speak with older cancer patients. And of course, we are trying to build several clinical models that are related to quality of life concerns when it comes to older cancer patients, like risk of psychiatric incidents, risk of frailty, late treatment effects, just to give you some examples. And then, as I said before, we are also trying to provide some end user applications for the patients. where we provide personalized educational content or motivational messages, which we are trying to use them in order to empower them to better self-manage their conditions and their symptoms. Patient-reported outcome measures or questionnaires that are being used in order for them to better track their symptoms or their quality of life, and of course some exercises that are relevant to mindfulness or relaxation, so that they can relieve their stress and improve their mental well-being. For the clinicians and the healthcare professionals, we also provide several tools where we're trying to visualize all this data. We're trying to aggregate all this data and provide them in a very easy way, an intuitive way, in a visual way, and trying to provide some clinical meaningful information. So we have three different views. The first one is the patient level data, where we're trying to provide some information about the activity levels, the sleep quality of the patients. I mean, data that are collected directly from the patients in an unintrusive way. We're also providing the results from the predictive models within this dashboard, and we are also trying to provide some cohort level monitoring, in the sense that for different clinics, for different team of experts, we're trying to categorize, we're trying to identify common phenotypes of patients, and in a way that it could help to personalize better their care plans and their follow-ups. So just to give you an overview of some screens and some intuitive user interfaces that we have built together with clinicians. And just to conclude my presentation, I just wanted to highlight that all these technologies that we have been delivering all these 3 years, we have tried to intensively include our end users, our patients, our clinicians. Even though the project started within the pandemic, I mean, the project started December of 2019, so you can all understand the challenges to include patients. But in the meantime, we identified ways and we tried to overcome all these barriers. So I would like to thank also our colleagues from ECPC for helping us on that, for bringing us together with the patients, the patient associations, the patient representatives, and that they followed. We go this journey together all the way. And of course, I would like also to thank the International Society of Geriatric Oncology, who have been our advisors during the implementation of the project, and they have been together with us all the way until now. So I will pass the floor to Ioannis, who is going to give you a brief overview about the big data technologies that we have used in the project. Ioannis?
Hello, can you hear me?
Yes.
Yeah, great. Okay. So, hello, my name is Ioannis Mavrodopoulos. I'm a PhD student in the informatics at the Aristotle University of Thessaloniki. And building up to the speech that Antonis gave, I will show you a little bit more information about how the data are transferred from the patient's house to the cloud. So starting about the data, as we saw, we collect data concerning the location of the patient inside the house, like the transitions from one room to another, and also some biomarkers like the heart rate, sleep schedule, and other things. And we collect them through these the devices like the location sensors, the Withink, SmartScale, Fitbit smartwatch, and the MoveSense T-shirt that we saw before. And these data are collected in a single location, but they pose some challenges. And these challenges concern the format of the data, the transition frequencies of the virus sensors, and also some cases, the metric systems that they are used. So in order to efficiently handle this data, we have to address these issues and provide accurate, reliable, and ready for further analysis data. So can you please, Jonas? Thank you. So instead of sending the data directly from the sensors to the cloud, we implemented an intermediate component, which is named Edge device, which is deployed on top of a Raspberry Pi installed to the patient's homes, and this brings computation capabilities closer to the patient. This proximity allows us to leverage benefits like privacy protection, location awareness, and low latency. Once the data are collected in the Raspberry Pi, they undergo some cleaning process in order to ensure that their structure is consistent and also remove null values and other processes. And then they are passed through a complex event processing engine, which runs in real time and detects predefined patterns within the data. So, for example, if we combine the data collected from the smartwatch and the location sensors, we can easily detect, like, for example, when a patient has fallen down. Finally, the data are aggregated before sending to the cloud. So instead of transmitting them per minute basis, we calculate the per hour or per day, depending on the measurement. And this allows us to optimize the network traffic and also enhance the performance of the additional analytical methods that will take place later. Can you go to the next one? Thank you. So once the data have been sent from the edge device to the cloud, they are pushed through a secure channel. In our implementation, we use MQTT, which is a secure message protocol that guarantees the confidentiality and integrity of the data. In the cloud component, which is basically a computer cluster, we run more advanced analytics, which include the weekly aggregations, like, for example, calculating the total number of steps per patient per week. And these aggregations give us enough information to discover some behavioral trends among the different patients. Additionally, as the data are now collected in a central location, we can analyze the correlation between the different measurements, both for each patient individually, but also to all patients at the same time. And with that information, we can detect outlying behavior, which is behavior that significantly deviates from the majority of the patients. So the clinicians can take a closer look and examine this, let's say, specific instance. And finally, we support the virus AI models that have been developed in the different parts of the LifeChamps project, like Antoni said, and we can support them in running in real time through using the pipeline that we built, and this allow them to seamlessly process the data. And finally, to conclude this presentation, I would like to highlight the strong points of the pipeline we built. First of all, it is highly extensible, which means that new sensors can be added and new calculation measurements can also be added with minimal code modification. Also, this pipeline is designed to be scalable, as we can simply add new machines in the computer cluster as the data volume increases. Also, the pipeline is proven to be fault tolerant, meaning that no data will be lost in case of a failure, and the whole process will continue exactly where it stopped once it's back online. Both the scalability and the fault tolerant are inherited by the underlying infrastructure, which is a combination of state-of-the-art open source tools specifically designed for big data projects like the LifeChamps project. And lastly, as already mentioned, the design of the pipeline allows us the extraction of information for each patient individually, but also detect trends and outline behavior by utilizing data from all the patients at the same time. So that's for me. Thank you very much.
Thank you very much, Yanni. So just to highlight here that it's very important that data quality is a must for building robust clinical models. So, and I think that also Vanya, who is next, is going to highlight this aspect that is going to speak to us about the design and also the different considerations around the AI clinical predictive models that we are building in LifeChamps. So Vanya, the floor is yours.
Thank you. Good afternoon, everyone. So I'm Vanya, data scientist from Capgemini Engineering. We have been mainly involved in the building of the clinical prediction models. And now I'd like to spend the next 7 minutes or so by describing you, let's say, the journey that we took within the scope of this project to build the clinical prediction models. And I may say that this can be thought of as a framework for any project that somehow wants to leverage digital solutions to deliver personalized care by incorporating intelligent components in it. So to build these analytics engines that are capable of providing these comprehensive insights at the point of care, we follow mainly 3 stages that I'm going to describe in the following slides. Next slide, please. Next slide. Yeah, thank you. So the first and very important stage, I would say, is to conceptually design the clinical predictive models. And in this process, all the relevant stakeholders should be included from the very beginning. So we run a series of working sessions with healthcare professionals to whom the actionable insights were actually going to be given, pilot partners that took part in the clinical study design and are responsible for data collection per se, the technical partners that are responsible for putting together the digital solution, and of course the data scientists, so the ones that are actually responsible for using the collected data to build the prediction models. So these are the most important for a successful, I would say, robust and meaningful personalized healthcare tool. So we divided these in 2 main phases. In the first one, we defined all the relevant clinical or care problems that modeling were trying to solve or support per relevant stakeholder and characterize them in several dimensions, from the target population, relevant and available sources of data. So are we going to have clinical and non-clinical data, specific variables that might be crucial to be collected for that specific problem, the frequency of the data collection, and of course, what is the expected outcome of that clinical model for that specific solution. So we end up with a huge list of user requirements, and then at the second stage, what we did was basically to build another framework to refine these requirement sets to get a final set of the most feasible and significant ones. Okay, so this priority setting approach was mainly focused on 3 criteria, I would say. How valuable the implementation of this model would be to that specific use case, how big was the risk for modeling for the modeling to have complications, let's say due to limitations in data collection, availability of resources, technical or recruitment difficulties for that specific use case. And of course, how valuable would be the implementation of this model to the whole project, okay, across all the pilot use cases. Next slide, please. So we ended up with a list of potential predictive clinical models to develop, being the one at the top in terms of priority, the clinical prediction predictive model for predicting the risk for frailty. Okay. Then next slide, please. In the second stage, what we did was to define a framework for analyzing specific types of data. Okay, and in the example we ran, we analyzed, for example, patient-reported outcome measures, which was basically assessment of the perception of the patient regarding specific clinical indicators, and symptom assessment scales and logs. So what we did was to apply several exploratory data analysis techniques to extract to analyze and extract meaningful insights. Meaningful insights more from a clinical perspective, okay, using data from a cohort of cancer patients. So these insights might and should, I would say, be used during the next phase. That will be the development of the prediction models per se. So just to give you an example, here you have represented, exemplified in this slide, one of the techniques that we included in this framework, which is based on clustering analysis. So this in particular is very useful to profile patients according to the reported symptoms, their symptoms, and also to assess how these symptoms are actually correlated with the several dimensions of their quality of life. And this can also be used, for instance, to compare specific groups. Let's say a group where you use the digital solution as an intervention comparing to a group where you did not, or even changes in these relationships between symptoms and quality of life during time. Next slide, please. Another very interesting technique that was incorporated in our framework is the application of what is called association rules. So basically to identify the most frequent co-occurring sets of symptoms or quality of life dimensions of these patients. So the knowledge of such patterns, such complex patterns, may lead to more refined clinical or self-management guides to cancer patients, and even changes in treatment or care regimes. So both examples serves as a proof of concept of how to analyze this data prior to the development of the models. Next slide, please. So we now got into the last stage. And these represent, in this figure, these represent the main building blocks for developing any clinical predictive models. We talked about conceptual design of the model at the very beginning. We talked about the exploratory data analysis, which is represented in the fourth and fifth block in this figure. I would like to highlight that the strategy followed to build the model per se should take into account four important aspects, which are models performance should be, of course, correctly evaluated using internal and external validation. So more than one cohort to evaluate how your model perform. Models should be explainable. The clinician should very easily understand what were the biomarkers, let's say this way, that most influence a given prediction for that specific patient and that specific time. Models should be monitored continuously to make sure that it's up to standards all the time. And lastly, and very importantly, models should be ultimately validated by the relevant stakeholders. So their feedback should be incorporated in an iteratively way since the very beginning until the very end. And only in that way we can actually guarantee that the solution that we are building does actually answer the problem that the end user wants to solve. But there is one thing that I skipped from this figure, and that I may say is of the utmost importance to guarantee before running any kind of analysis, either advanced or predictive analysis, which is data quality screening. Next slide, please. So it is estimated that over 1/3 of artificial intelligence and analytics projects fail due to data quality. And for that exact reason, we decided to incorporate the data quality standards into our process in order to bring robustness and control over the data that we are assessing in a more sustained and controlled way. So I just would like to highlight some examples of challenges that we faced when screening this project data for its quality. And that I think are actually transversal to this kind of projects. So where we aim to build digital solutions that are actually going to be used in specific populations, such as older cancer patients. So one of them refers to timeliness. So one factor that we should take into account during the design of the study is, for instance, patient adherence and patient diligence. So patients might not always adhere to the protocols, so adding a layer of uncertainty and noise into the data set. And this noisy component is going to be propagated to further analysis, including the predictive models. Next slide, please. So another very good example relates to completeness. So sensor data are highly, I would say, highly susceptible to technical issues or even misuse of the sensors by the patients. And this might result in high presence of missing data that are actually compromise their utility in further analysis and put an extra effort in adding to the pipeline more complex and robust techniques to process the data and input the missing data. So this is especially critical when the recruitment of a high number of patients with the main benefit of collecting more data is not really viable. Next slide, please. So these are the most important stages for having a more robust model development process. So in building these robust models, we move somehow towards a personalized intervention and treatment plans, improving in this way, I would say, the patient's outcomes and quality of life, and ultimately enhancing the healthcare decision-making in cancer care. And this is all I would like to tell you today. Thank you.
Thank you, Vanya. So I will move on to the last part of this slot of today's event. So Panagiotis Kartsidis from Bristol University, he will present us how we aim to pilot the LifeChamps solution in real life and some key findings that we have identified so far. Panagiotis?
Yes, okay. Thanks, Antonis. Thank you, Vanya and Yannis. And I would like to thank you for having us here. So, the first thing when we want to create predictive models is to train them. And to do that, we run a preliminary data collection for the predictive model training. This took around 5 months. It had a duration of 3 months per patient. It involved patients after initial treatment of melanoma, breast or prostate cancer, which that were over the age of 65. It ran in Sweden and Greece. During the 3 months, the patients wore the smart watch on phone and used the light version of the mHealth app developed for LifeChamps project. And we installed some sensors in the homes and we collected data. In addition to that, we used the EHR data from the retrospective EHR data from over 1,000 breast and prostate cancer patients applied from Spain to augment the training of the models. And currently, we are, please, next slide, thank you. We're running a real-life feasibility study in the same population. This is patients that are after the initial treatment of melanoma, prostate, and breast cancer, and again over the age of 65. This time in Sweden, Scotland, Spain, and Greece. The duration remains the same. The patients will wear the smartwatch and use the mHealth app on their phone for 3 months, and we will install the sensors of the LifeChamps platform in their homes. But this time, data collection is not the primary objective. The primary objective is the evaluation of the platform in terms of feasibility, accessibility, usability, effectiveness, and of course, the validation of the predictive models. The plan is to involve 120 patients, and it uses a pre-post study design because it's really hard to control for covariates in this kind of populations and in 4 different countries. The cities involved are Glasgow, Stockholm, Thessaloniki, and Valencia. Thank you. Before and after the usage of the LifeChamps platform, we collect endpoints for quality of life, frailty, and cost effectiveness. And during the 3 months, we also collect questionnaires via the mHealth app regarding quality of life, frailty, side effects, medication adherence, anxiety, depression, and illness perception, all this to validate the predictive models. Using the aforementioned sensors by Antonis, indicatively, we collect the heart rate, SpO2, physical activity, sleep patterns from the watch, weight and body composition from the scale, the sleep duration and time spent in each room using the ambient location sensors, and TV usage time using the smart plug. Next slide, please, Antonis. Thank you. And let's move on to the current progress of the pilot. We have managed to recruit 85 patients across the pilot sites, of which 74 have the LifeChamps platform in their homes right now, or in the past for 3 months. On the left, you can see the main visibility variables, which are the recruitment, dropouts, and new enrollments per month, where the active patients are patients that have the platform installed in their homes. And on the right, we have some preliminary data showing us that the patients used on February 9 times on average the mHealth app, 2 on March. Overall, the patients used 9 times per month the mHealth app, and we have broken it down per month on the right. And each session had an average duration of 20 minutes, and each patient accessed 10 educational units, which are incorporated in the mHealth app, and attempted 2 quizzes to check their knowledge on what they've learned via the units. Thank you, Antonis. Next, we measure the adherence to the protocol, meaning how many patients and when do they fill out the questionnaires via the mHealth app. We see a natural decline in adherence, but it's not zero. Keep in mind that this data are preliminary. Up to this point, RPC has, the pilot in Sweden has the highest adherence to the prompts collection, and we see a stabilization to 50% in Greece. Finally, regarding the sensors, only 7 patients followed the protocol for weighing themselves every week, and 14 of them did it 75% of the time. And the good news is that our patients seem to wear the smartwatch, with 47 of them having it for more than 24 days per month, 38 from the second, and only 12 on the third month of their participation. When a patient finishes the participation after the 3 months of the usage of the platform, we have an exit interview with them. So please, Antonio. One of the questions is, what did you learn from your participations in this time? And these are anecdotal replies. One of the patients replied that they felt really positive about their participation. They felt that through their participation, they help other people, which is of great value to us. They also learned to use the technology and check their data through the smart devices. And one patient said that they couldn't say they learned something new, but they liked that they check their heart rate every day. Another question that we asked and we received interesting answers is what was the aspect of the LifeChamps study that they liked the most? What was the activity? And the answers we received was that the real-time monitoring of the HR again, that's from a different person, and they liked the fact that they could check their activity levels, but they didn't know how. We told them that we are counting your steps, but they weren't very adept to the technology to use the smartwatch efficiently. One very interesting finding to the question, what did you least like about LifeChamps study, and what do you think can improve, is that they don't have something negative to say. However, regarding the questionnaire that we administered via the mHealth app, there were some questions specifically referring to their disease, and it felt weird. Are the questions relating to cancer? Because it should be made clear, because they perceive themselves as healthy, not a cancer patient anymore. And last but not least, a patient didn't like the fact that they had to remember and get reminders for doing things for our study. As I said, these are all preliminary. Thank you, Doris, and thank you all.
Okay, and I think this concludes this slot of the.
Yes, thank you all for these valuable insights into the outcomes of the LifeChamps project. We definitely move ahead. We are a bit short of time, and we move to the discussion panel. And in this sense, I would like to welcome here Wendy Yard, the director of the European Cancer Leagues. Welcome, Wendy. Vance Van Hoof, the scientist from Cienzano and involved in the last joint action. Welcome. Petros Soundoulidis, who is an associate professor of neurology at the University of Thessaloniki. Welcome. Again, Antonis Vidis, the scientific coordinator of LifeChamps, and also online we have Kino Bresson, who is advisory board member of the LifeChamps project, and he's also a radiology consultant and digital clinician scientist at Charité. Welcome. Tush Smith, she's a scientist at Cienzano, involved in the ICANN joint action. Welcome. And Tom Flynn, who is the leader of the cluster Cancer Survivorship, AI for Wellbeing. And also he is working for the Innovation and Business Development Manager at TFC Research and Innovation Limited. Welcome to all of you. I have some questions, and I'm sure that also the attendees are willing to find more about your insights related to the roles of research and innovation in the digital transformation of cancer care continuum. And Antonis, because today is about the LifeChamps project, I will address the first question to you. So how important are actually the digital skills for both patients and clinicians? And what digital skills are required to enable the adoption of innovative digital health technology in the clinical practice, but also beyond?
Yeah, certainly there are things that need to be improved in terms of knowledge and skills, both for the patient side and the clinician side. I mean, we've seen that when we tried to approach initially within the LifeChamps project, both the clinicians introducing these new technologies like the new sensors and the data that we aim to collect within the project, we really find several obstacles to do so. I mean, the clinicians, they didn't accept to have such kind of technologies, especially when it comes to put this technology inside the homes of their patients. So they were quite hesitant. And I think that certainly we need to increase their knowledge in these new technologies, in these new sensors. And of course, what needs to be improved is also to better understand the data that come out of these new technologies and these new devices. So I will say that data literacy is something that certainly needs to be improved. There are cases in other professions, like journalists, that they go through data schools So I think that certainly we can try to elaborate a bit more and develop some kind of data schools also for healthcare professionals so that we can increase their data literacy. And apart from that, it is very crucial both for patients and clinicians to be actively involved in the design and the development of these technologies. As you may have seen in LifeChamps, we've tried to actively involve the healthcare professionals in the design of the models. So this has been performed iteratively, and we aim to, in every step of the development of the algorithms and the models, we aim to receive their feedback, improve the models by incorporating their feedback on that. And we have, also in our user interfaces, we have included them in order to develop the new insights. And this is the same case for the older adults, right? We need to include them. It's not about digital literacy, and I think we need to move from that paradigm to digital fluency. And we can achieve that by putting in the center of the innovation the patients and the healthcare professionals. So it's not that they should be passive recipients of the new technologies. They should be at the core of the innovation. They should be the ones that they will provide the ideas. And to do so, we need to include them in more active ways of co-creating, using new forms of innovation, schemas like living labs, etc.
Thank you, Antonis. You brought here a very interesting perspective, and I would like to see what's the opinion of a clinician. So, Petros, you are a clinician, and I come to you now. Do clinicians actually face challenges in adopting digital health technologies, and where do you see the barriers?
Thank you. That's a very interesting question. I would like to take it one step further from what Antonis just mentioned. It is crucial to have a very good collaboration during building the models between ourselves, clinicians, which are theoretically the end users of those applications, and the guys who work in the lab. So during our collaboration, those 3 years, there were times that we understood that there was a lack of information or a lack of understanding between the guys in the lab, the guys who are developing the application, and the clinical endpoint of this project, which is something that was modified during the procedure. And this is one thing. The thing that you asked, the question was about implementation of the technique of artificial intelligence in the healthcare system or in the patients. If it has to do with the patients, my experience with the LifeChamps recruitment was very positive. And one thing that always came up in the discussions between patients and ourselves was the fact that they needed to trust the individual, who in our case is the physician, in order to get involved in this type of project. Because it is, I would say, not inclusive, but we had to go inside their homes and install appliances. And they had to wear the tag and the watch for 3 months, which is not easy, if you think. It was not easy for us to actually sometimes propose this. But we found out when the study was going on that was not a problem after all. I believe that what Panagiotis showed, that none of the patients withdrew from the study. Sorry?
Yeah, dropped out.
We had zero dropouts.
And also, if I may add to what you were just saying, Petro, it's also the fact that they have forgot about the technology after some time.
Yes, this is also very important because this was our concern in the first place. How are we going to propose to a patient that you will need to wear the watch for 24 hours? Remember to wear the tag when you come home. So that was not easy. But we found out after some weeks and months that getting feedback from the patients. Actually, the first couple of weeks, I was very not so optimistic that, let's say, the majority of the patients would drop out after a couple of weeks. But the opposite happened. And my feedback as a clinician was that the patients were happy in a way that they had the feeling that someone was watching over them during the project. And this was very positive. This is not something that we expected in the first place. We're thinking that this would be intrusive and it will disturb their lives. And let's say the majority will probably say, okay, that's enough for me. But the opposite happened. And one point is that, and the second point that I already mentioned is the level of commitment and the level of relationship that we are building between our patients and ourselves. And this is very important. This is what my most important lesson from participating in the study, apart from meeting those nice gentlemen in the group, was the fact that I gain more belief in what we are actually doing as doctors, really. Because I see in practice the relationship and the bonding between the patient and ourselves, and the trust that goes with it.
Thank you very much. I will stick to patient engagement and the lessons learned. And I would like to ask Tom, who hopefully can hear us from online. Tom, you are leading the Cancer Survivorship AI for Wellbeing project cluster. Can you please tell us how important the engagement of patient association is in the process of cancer survivorship care? And are there lessons learned about the business acumen aspect of the EU project outcomes?
Greetings from a very warm Galway. Lovely to see you all, and thank you for having me at this wonderful panel session. To answer your question, you have to look at the picture differently. If we think about a patient, there's a lot more to solving the problem than just technology. There's a lot there. The patient's health, the well-being, all these things are so critical, which is fine to say. But I think the critical part is that when solutions are developed, how do we bring them to the marketplace? And this is an entity of what we formed, the cluster group. And the cluster group is fundamentally a number of projects working, as we say, not in silo, sharing problems, sharing issues, caring for one another. I think that's very well said, because we all have problems with our projects, but we all have the same intent. In other words, to live the very best we can so that the physicians and doctors can do. So the cluster came about, I think, primarily from the knowledge of let's try and work together. Let's share knowledge and experience and so forth. And on that basis, I think it's working extremely well. Without question, patients associations, critical. I cannot use that word enough. From our point of view, we brought patients in and held a workshop with them, and I'm delighted to say it was a challenge, but it worked extremely well. And from that, it evolved where we said, absolutely, why are we just working with one or two patients who are supporting it? And we're very welcome to it. We decided to bring the patient association and had listened to them and their knowledge and understanding, not only from the project's point of view, but from the patient's point of view, was warmly understood, warmly welcomed. And it became very, very important, the message said earlier on. We've got to get them from the beginning, not just at say the requirement stage and not a validation. And the emphasis there is to bring it forward with them, the whole entire project, so that in future projects, in future work that we do research, that they will become a core entity. And we touch base at critical milestones because they're aware of the wider market, they're aware of the fresh concerns that are coming in. So we bring their knowledge to our work, and therefore we strengthen our output, knowing that by the time we finish the project, we have been as close as we possibly could to the patient. And that's one of the principles that we followed through with it. So I think that's a remarkable way going forward. But if you take it a step forward, on the same principle, we have to engage with the outside world. We have to make sure that when we deliver our solution at the very end, there is a life for it. It doesn't fit in the lab. And thus, the concept we applied was, let's bring the business acumen into our projects. Let us show them what we're doing. Let us understand their perception of what they need that they can bring to the marketplace. Now, clearly in our area, because all the medical restriction regulations and so forth, it's not straightforward. But their knowledge of the subject matter and what the market needs was invaluable. So we are now working very closely with a number of business acumen experts, those that would be in the business angels area, and they will now join the cluster group as an entity, so that when we are moving forward with future proposals, future projects and so forth, we have their capability and knowledge, and they will help us say whether or not that we're developing something from a business point of view that's going to work. So I think there's some I think there's some important comments in what I'm saying to you, that it's not just about the patient being very critical, but it's also very much about the right people working with the right time to make we deliver as best we possibly can our results to the marketplace. I hope that makes all sense to you all.
Thank you very much, Tom, for sharing this interesting perspective. And now, because today we heard several times about the importance of quality data, and
Yes.
I would like to move to you because you are involved in the Comfort project, and I would like to know, how is this project planning to unlock the full potential of database solution in the fight against urologic cancer, and what strategies should be followed for comprehensive training of clinical teams to improve digital health literacy?
Thank you for having me. So to collect the data, to use the data, we have to collect it. So we first aim to collect diverse sets of data, like similar to LifeChamps. It's not just imaging data for us. We try to access as many data sources as possible. And we honestly just try to first collect everything we can from this. So for us, is a lot of imaging data, but it's also clinical data, text-based data. Problem is it's highly unstructured. And to somehow get a structure into this, we plan to use AI models. So recently, this played in our hands with the success of the large language models such as ChatGPT. Obviously, you can't use ChatGPT on patient data, but there are several language models already developed you can host locally, and they are excellent in structuring data, going through text data, going through tabular data, and converting it into structured formats. So excellent data extracting methods for this. And then those same models are also very good in combining data. So what we will do is we will use the data and then combine it, let's say, in a mathematical space. So use the models to convert it to a mathematical representation, and then you can combine the data and leverage this multimodality. And those models allow that they not only look into features we predefine, let's say the extent of the cancer, but also more features we might not be aware of, and they can do much more correlations in much higher dimensions than people can. I mean, we can only remember up to 7 things simultaneously, but machines have no problem in doing thousands or 10,000 things simultaneously. And with that, we hope we will unlock this full potential of the data in our project. The second thing, how we have to train clinical teams to improve digital health literacy. I actually think there are 3 important steps here. First thing is we need to know the perspective of AI. So what are the expectations of the clinicians and what are the reservations? Because only if you know what they expect, you can also teach them and educate so that resonates with them, that answers the questions. And then what we really need is interdisciplinary exchange. This goes way above and beyond to workshops. We need people from different fields actively working together and communicating together on a daily basis. Because what I saw is that the 2 fields don't understand each other that well. So healthcare is often underestimated in its complexity, because in healthcare we have this inherent uncertainty. So we're never 100% sure of the diagnosis. Well, mostly we're not sure. I think a bone fracture is the exception, but most of the other diagnoses, there are strong indicators, and we can be very sure, but we can never be 100% sure. And we sometimes see this, that diagnoses are revisited or changed after 10 years with new evidence. And this is something which is kind of unique to healthcare. And if you are a computer scientist working more mathematical realm, you're not used to this kind of thinking, where you're more logical thinking to something that has logical absolute solutions. And then the other way is also that sometimes computer science AI is overestimated by people from the healthcare side. So it's very hard to understand what AI can do and can't do. Sometimes very simple solutions computer scientists can do are thought to be impossible to achieve by healthcare professionals. Then other stuff where people say, oh, that should be easy to implement, is actually very hard. And only if people talk repeatedly with each other, with the exchange ideas, if they exchange how they approach problems, I think then people start to understand, and this will foster this literacy or this fluency in data and AI. And the last thing is we obviously also need workshops and teachings, but I think this is the least important. Of course, sometimes if we start a project, we have to do workshops together to teach focused what we want to do in the project. On the comfort project, we will do teachings on neurological cancer for computer scientists. We do AI teachings for healthcare professionals. So they are on the same page, but this cannot replace the cooperation over years where people learn from each other.
Kina, thank you very much for this interesting perspective and for sharing this very tremendous work, and also putting it into a future perspective related to what the clinicians should do further, but also about maybe where the policy plays a role, because now we are at the European Parliament. And I would like to stick to the aspect of data, but this time from a citizen perspective, because currently there is a lack of clarity for citizens regarding the use of health data for purposes beyond individual care, and this hampers, of course, the cancer research. And once I will come to you, what solutions do you see in this sense, and how does the VEDAS project aims at addressing these challenges?
Yeah, thank you for the question. I think in general, I really like what Petros was saying about sort of changing the narrative to where you're thinking maybe as a physician or as someone using data that you're burdening patients, like we're invading their privacy, we're using their data, we're sort of exploiting them, whereas actually it might be the exact opposite. Many of the citizens and patients who shared their opinions on our platform, they were first like their initial contact with the platform was a piece of information, like this is currently possible, this is not possible, what do you think, should this be possible? For example, it was like cases like this, and many of their reactions was like, isn't it obvious that this should be happening? Why isn't this already happening? Why aren't you already gathering these data? Or if this already exists out there in the world, why isn't there an algorithm keeping track of this? Why isn't this already like self-evidently implemented? And that was one of the major lessons that we had. And so the concept that we developed based on the input of 6,000 citizens, European citizens, about what the secondary use of data and health data should look like was the idea of conditional beneficence. The idea of like, well, actually our first response isn't like you need to protect us or we don't want to share our data or this is our data. No, the initial response is like, yes, especially imagine being a cancer survivor and having the opportunity that without doing much of anything, just being tracked or just living your life, being able to improve the situations of other cancer survivors. That's amazing. That's something that gives meaning to your identity, to your history, to something that's really happened to you, and that's an opportunity. And so I think we have, from the point of view of the EHDS, a huge responsibility to develop a framework that facilitates and enables benefit to come from data that already exists, to come from pieces of people's identity, pieces of people's history that are out there in the world, and they have this huge potential for good in there. And I think the way to do this idea of conditional beneficence, is to sort of live up to a standard of trustworthiness. And trust isn't something that you can decide on your own. I can just say, hey, now you're going to trust me, and this is now there is a bond of trust between us. No, trust is a relationship that's based on certain elements, like conditions, where you're like, yes, I will trust you if you behave in this and this and this way. If, for example, you're going to use the data for good, purpose is very important. If you can clearly define to me, this is what I'm going to do with this data, this is how I'm going to protect you, this is going to be proportional. For example, if I'm doing something that's immensely beneficial to you as an individual, then maybe the protections in place need to be less high because it's proportional to the potential benefit for you as an individual. If it's a small individual benefit but a huge societal benefit, or for your community, or for your direct family members, for example, again, everything can change. And we need to build this dynamic framework that's based on citizens and patients' values and principles. And that way we create this trustworthy system where people can see, oh, this has the HDS stamp on it. This means that it's built in a certain way, that it has certain quality standards, and that it will be used for good. And then I can just say, okay, yes, this is a place where I feel comfortable. This is a place where I trust my data to be in good hands. And if we're able to create this type of framework, fueled by patient experience, fueled by patient values and principles, then I think we're living up to the responsibility that we have to the original, to the data originator, the person where the data came from.
Well, thank you very much. This is definitely a game changer if we think of the implementation of the European health data space. And hopefully, if we see the regulation in place till the end of this mandate as promised here in the Parliament. If not, definitely after 2025. But yes, this should definitely be a game changer, and this should, promote the patient involvement in cancer research. Thank you very much. And there is one aspect that we haven't talked about today, but this is very important from a policy perspective. And this refers to inequalities in cancer care. This is something that is very well mentioned in the EU Beating Cancer Plan and also in the Becca report that the Parliament voted on. And I would like to go to you, Tash. In terms of access to digital health technology, how can we address the inequality gap? What are the main factors that we need to focus on, and what solutions will the ECAN that you are involved in provide in this regard?
Hello, everyone. Thanks so much for inviting the ECAN Joint Action. So my name is Tuğçe Schmidt. Very happy to be with you today. And in this joint action, indeed, as you mentioned, we look at the inequalities. So I think there are two types of inequalities. One is to emphasize the inequalities within countries, and the other is the inequalities between countries. So how do we handle inequalities within countries? In the European countries, I think, and it applies to all member states, we should differentiate three levels. So one is looking at the patient level, so it is the micro level. The other is the meso level, so it's the HCOs or the cancer centers. And the other is the macro level, understanding the policymaker perspective. And if we want to reduce inequalities, what we should do is that integrating these telemedicine services that we are piloting within the ECAN Joint Action to standard care. So regardless of their geographical proximity of the patients, regardless of their income, regardless of the type of the healthcare system, it can be the statutory healthcare insurance, it can be national health service. We should look at the countries and understand what their needs are. And it's exactly what we do in the ECAN Joint Action. We try to understand what the patient perspective is by collecting data, patient-reported experience measures, and also on the patient-reported outcome measures. We also develop an ECAN app, and through this application, we collect data, so prompts data. We look at HCOs, the piloting healthcare centers, the cancer centers, and we try to understand their perspective. We analyze through the SWOT analysis, so strengths, weaknesses, opportunities, and threats, and understanding what their barriers or facilitators are. And we also have a foresight exercise and roadmap development. We pay attention to the sustainability of this joint action. So we try to understand also the policymakers' perspective through this exercise. I think these three levels are key in order to understand the reduced inequalities within countries. So when we look at the inequalities between the countries, in European countries, it is all about understanding, again, so how to integrate so those services into standard care and offering them tailor-made solutions. Because it is not really a top-down implementation approach through this joint action, and I think this applies to many European projects. It is all about understanding their perspective, the member states' perspective, and probably they have also legitimate reasons why they can implement a technology, one technology, and they cannot offer solutions for other digital technologies. So if we understand their position, I think it will be also easier for us to offer good solutions. So be it for telemedicine. So in the ECAN, we have two services, so teleconsultation and telemonitoring. And for that, we should have a flexible framework and put ourselves into their shoes, so understanding the member state perspective. And in this way, I hope that we can reduce inequalities within member states and also across Europe.
Well, thank you very much. This was definitely a different but very interesting angle of the cancer care and the cancer continuum for patients as well. And last but not least, Wendy, I will come to you because ECL is involved in several new projects that are linked to digital health. And can you tell us more about the challenges that you've encountered, but also about the opportunities?
Yeah, thank you very much. And who knew that there's so many apps out there related to cancer, and who knew how many projects that are funded by EU here. So Antonis and we're working together on one, for example.
100?
Sorry?
Tens?
Yeah, I think there are many. So this was really interesting. So congratulations on the LifeChamps project. And it seems extremely complicated, all this Internet of Things, and I'm, jotting notes because I'm learning a lot, and I think I can apply some of what you guys have learned to our projects. I'm going to mention 3 different projects that we're involved in. 2 involves mobile apps, and 1 is a digital tool. So one is one is a EU funded project called Wasabi. It's ended now, and it was actually an app focused targeting young people. So we actually don't have the challenges that you guys have over 65. Getting them to be involved, and it was a very successful. It was a very successful project and a very successful app. And the challenges, I would say, overall, for this one in particular, is the life expectancy of these apps and also the sustainability. So, for example, Wasabi, it was working really well among the young people, but then on the tech side, there was a glitch, and so now it's no longer working. So what happens then after 3 years? You invest all this money, and then on the tech side, something goes wrong, and the money runs out because the EU is not going to fund it forever. So what do you do there? And then also competition. There's so many apps out there I just mentioned. So how do you, when you put it on the Play Store, what attracts them? Okay, I'm going to download this because I want to lower my risk of cancer. Oh, but then there are all these other ones. How do you determine what works? Right, and then so that's those are the challenges for all our projects I'm going to mention. So that's for Wasabi, and then the current one that we're involved in, and we're actually leading the whole consortium. So I understand the complexities of having to lead a consortium, and Helena Ross is actually our project leader here, and she can tell you all the headaches that we've had in leading such a consortium. But we're also working with a tech partner. So going back to what, who was it? I think it was Kino. You said, talking about how do you connect the different fields, the players. So we've got our cancer experts feeding into the tech side, but then the tech side understands something from the tech side, and then we understand something from our side. So how do you make the 2 worlds meet, and how do you all agree? Not to even mention aligning the timelines that the European Commission has imposed on us versus on them. And then how we have to make sure that this app is supposed to help the normal citizen decrease their risk of cancer by using the European Code Against Cancer. How are we going to make this attractive enough for everyone to want to download? So all different age groups, but we're also focusing on the more displaced, like migrants and underserved populations. How do we do that? So that's going to be another challenge for us. And then I want to talk more about the opportunities here. So the opportunities are, we're presenting up there where, there's so many apps out there now, and people are already getting used to using them. So we feel that we're also contributing, to the whole tech side and getting people more interested. in using technology. I think COVID has really helped us, has helped the healthcare professionals, the patients adapt to, you know, what they used to be allergic to, you know, the tech side, that you have these clinicians who don't want any web consultations, and all of a sudden they were forced to, and now they like it. They're like, oh, you know, maybe you don't come into the office. I can tell you all about it online. So you've got that side, and we feel that, you know, here's an opportunity. We're contributing to that, you know, and then the European Health Data Space is also going to help us, hopefully, by encouraging citizens and letting them know that their data would be protected, but also for the researcher side, that yes, you know, the data would be protected, but we're also going to still let researchers use the data. So we need a balance there with the European Health Data Space. So I think there's an opportunity there. So for the bumper, that's also linked to the Europe Speeding Cancer Plan, where the cancer plan says that it aims to make at least 80% of the population aware on the prevention messages in the European Code Against Cancer. And then I want to lastly mention another project that we're involved in. It just, so we're involved in dissemination of it, and it's called Painless, and you can get more information. It's a very interesting project. So I encourage everyone here to go to like @EU Painless to learn more about the project, because it is a project where, you know, patients go through a lot of pain when they're going through treatment, when they're just even affected by the disease. And, you know, how do you combat that? How do you make that easier for patients and also the clinicians treating them? And the Painless project, they're going to be using an AI algorithm to develop tools to predict pain in cancer patients, to counteract that early. So imagine, you know, even before, you know, people who get migraines, I'll just use a more common example here. You know, what if you knew that you're gonna, okay, a migraine's gonna come on in a few minutes or in an hour. So, you know, we're warning you so that you know that, okay, you're not gonna make that presentation, or you're gonna go in a little bit later because you're gonna have such a big headache that you won't be able to function properly. Or, you know, if you're gonna be working on an assignment, imagine if you have that AI predictability to help you be able to combat that. So that's a project for Painless. So these are all the opportunities and the challenges, but I would say, again, going back, I think the biggest challenge for all these apps is, you know, how do you keep it going? How do you get people to download it? You know, sustainability, life expectancy, when the money runs out, we have all these. So I'm very curious to know from the LifeChamps project a few years from now, you know, what did we learn and what are the follow-ups to it? So thank you very much.
Well, thank you very much, Wendy, for sharing these interesting perspectives. It's a lot to learn from each project, and I think collaboration will definitely benefit us. And because we are running out of time, I just have one short question for all the speakers. If you can tell me in 30 seconds, because we stick to opportunities, what opportunities do you see in the near future regarding the implementation of digital technologies? And I will start with you, Antonis.
I mean, the vast amount of data that we are collecting at the moment, and the chance that we have with the implementation of the European Health Data Space to use real-world data in the research and also in the development of new novel technologies is something that we should not miss, this opportunity. And I think we should try to build on top of this.
Thank you. Petros, I come back to you.
Right, so this is a challenge. We still don't know. I think that AI in healthcare is still in its infancy, I would say. So there are challenges ahead, there are problems we need to face. Speaking as a urologist, artificial intelligence is already in the prostate cancer guidelines for the European Union in terms of early diagnosis of prostate cancer. And this is the first time in the guidelines of 2022, I believe, that artificial intelligence was adopted by the EU guidelines for prostate cancer for a specific reason, in this case for diagnosis of prostate cancer. So I am personally positive. I think that this is the way to go forward in certain aspects of healthcare. It is a big discussion whether this could be just limited to diagnosis or even treatment or even surgery. It's still a way to go. But personally, I'm positive. I think that in the years to come, artificial intelligence and big data will be a part of our everyday clinical practice. If we are able to overcome this period of childhood diseases for artificial intelligence.
Thank you. Tom, what about you?
Sorry, my apologies. I pressed the wrong button, which I'm traditionally doing all the time. So delighted. My thoughts are very clear. I think I agree. I think the industry is in its infancy. I think if we do comparisons, I think where we were with drones maybe 10, 15 years ago, we are at the same position where we are with artificial intelligence. Fully believe that the deep learning models that are coming up will have a tremendous impact on supporting the physicians to understand what's going on in real-time mode so they can act more swiftly. And I think we've also got many issues from regulations point of view and standardization issues to overcome. And we have technology problems. For example, batteries life and some of our watches and devices don't give us sufficient high quality because they run out. So we've got many problems, not just in terms of the technology we're developing, but also the periphery stuff that we rely on. And so it has to come together, and it will come together in time. But putting that all at the center, it will happen because it's happening in all other industries, and our industry here will also be in that league. The problem we're going to have, which is more of an ethical issue, is that if something goes wrong, who do you blame? Is it going to be the physician, or is it going to be the technology? So there's issues like that to be overcome as well, which are very much on the ethical thing. So we have a lot of challenges ahead of us. But are we heading in the right direction? Absolutely. Will it happen? Uncertainly, it was going to happen as well. Yes, I'm very optimistic.
Thank you very much. Kino?
I'm also optimistic. I think we're getting close to whatever Topol envisioned with the deep patient representation, a digital representation of the patient, combining all the data we have in the hospital, which allows us to really dig deep, find digital twins, and maybe diagnose patients faster and more accurate than ever before. But I think one of the main challenges we're facing is striking a good balance in AI, especially regarding to regulation, because it's not a lack of innovation we have in AI, it's a lack of getting the innovation to clinic. And here the problem is it can be over-regulated very easily and under-regulated very easily. And I think that's one of the main challenges we're facing to get AI really into healthcare.
Well, thank you very much. Very interesting indeed. And I move to Vance.
In terms of opportunities, I also see sort of similar an ethical issue, but more in terms of like when I see digital technologies, AI, big data, I see like the matrix, the green letters running down the screen and the people looking at the screen and seeing a whole world. I think we all interpret the world through data, and the more data we have, the better our interpretations become, which can potentially lead to this positive spiral where more data leads to better interpretations, leads to better treatments and more benefits, and then you get into this positive vibe and spiral, and that promise is huge. But I think the big ethical issue is that there are things that are hard, really hard to measure, that are very important, things like identity, things like values, things like ethics, that cannot be overlooked, and that might not be a part of this initial success story and positive spiral, but that might lead to problems down the line. So I think the potential is huge, but we need to be wary and we need to keep good oversights. And so my main worry is like overregulation will lead to things slowing down, but underregulation will, I think, lead to huge problems down the line.
Thank you very much. Dušek?
Thank you for the question. I think when talking about the digital technologies, even in the near future, it can go even beyond our imagination. So what kind of solutions that they can offer? So we talked about telemedicine, teleconsultation, telemonitoring, use of AI, primary use of, secondary use of health data, EHDS, and so on. So imagine what can come up in a few years. Maybe we do not know the answer, but what is for sure is that healthcare systems in Europe will be more preventive, more integrated, and more person-centered. So any kind of data-driven innovation that will support these three qualities will be key, I think, to think about. Thank you.
Thank you too. And last but not least, Wendy.
Thank you very much. So in terms of opportunities, I already mentioned acceptance, and I want to stick to that. I think it's really helpful for the general society to accept it more. But I also want to say that we should also be wary that they also prevent opportunities for the dark side, for the darker players. They will use the data to their own good, and we have to be ready for that, and not just think that everyone is kind and wonderful, and that our data is going to be used for good and not for bad. And then I just want to say also, AI, it is kind of in its infancy, and I think I see it developing. It's going to develop so fast, and we have to be ready for that speed. Because I still remember just 2 years ago, we were talking about the ethics around AI, and then we were also talking about how people might lose their jobs. And then all of a sudden, ChatGPT comes along. Everyone is embracing it and saying, I'm going to use this for my homework. I'm going to use this, in the clinical setting. So we went from, I'm going to lose my job. I don't want anything to do with AI to give me more, give me more. So I think opportunities for everyone. We just need to be aware and be ready for it.
Okay, thank you so much. And now it's time for questions and answers. And I think that also the attendees have questions for the distinguished panelists. And if you are in the room, please raise your hand. And if you are online, please drop your question in the chat.
Am I allowed to raise my hand?
Yes.
Yes. So I have a burning question. Did you have to train your participants who are over 65 years? Did you have to train them? Because it's so complicated with this whole Internet of Things, and I could see that they were wearing smart watches, and I could see that they were dropping. And I think it's not necessarily because they were not wearing the smart watches, but maybe because they forgot to charge them. So did you have to train them? How did you get them to know more about, how to use the devices? And because we're facing a kind of similar thing, we're doing a train the trainers thing. Did you also have such a step in your project?
Are you going to take this question or maybe?
Well, yes. We had to train the trainers. We developed the platform with the patients, not the same ones, of course, but they were involved in the development. But especially for the preliminary data collection, the data that we used to train the models, we had extensive training, and then we made some calls, and we forgot to sync your watch, because the primary goal was the data, and they knew that we are going to do that. Now we just give them the watches, show them once how everything works, and then just check for technical issues. Like if you forgot to charge your watch, so the platform doesn't work for you.
But key here is also that you need to include sensors and ways of collecting the data that do not require too much effort and does not steal time from patients. I mean, patients are already overburdened with the care of their disease, with self-care activities. It takes a lot of time. You do not want to put extra effort on them, on their shoulders. So, I mean, even the questionnaires that we have selected, they were selected based on the assumption that it won't require too much time for them to complete, and the frequency that they need to complete these questionnaires is not too often. So all this we kept in mind, and as mentioned before, we tried to keep the technology as unobtrusive as possible. So the sensors that we selected, they were chosen on the unobtrusiveness factor, for sure, so that they tend to forget that they have a technology that monitors them in everyday life and is not, as Petros mentioned, it does not disrupt their daily life. Yeah, that's important. Yeah, especially if you consider that you need to monitor them for a long period of time, right? That's a challenge, because I think that probably the period of time that they had to participate in the study was also a factor that really hindered them from participating, right?
Especially Given
months.
the summertime
Ah.
that is coming up, yeah, we had a lot of prospective participants that said, oh, yeah, but how long? 3 months, like June, July, oh, no, sorry.
Yeah.
I personally go to rejections that way, but we try our best.
That's the drawback of summer in Greece.
Yeah.
Do we have more questions in the room or online?
There are definitely no questions from online.
Okay.
We asked 2-3 times, our colleague. But I have a question very quick. I know it's evening. Maybe that's the reason why nobody. Maybe you partially covered that. It's to you, Wendy, but also for the other participants. You mentioned that key challenges, biggest challenges are life expectancy and the sustainability of these apps. My question is, if you have some advice, or what do you think is the most valuable to overcome these challenges? Is it about money, finance? Is it about to have a user-friendly? Is it about some collaboration with, you mentioned, of scientists, data head specialists, and who was it? About cooperation of that, the app developers, you mentioned it, I think so. Where is the key of sustainability of this kind of app?
So we're still learning, but I would say that it does involve financial issues, concerns, and it also involves the competency of the app developer. I would say learning from already one project, you need to make sure that you have a robust contract with them that they will be able to honor, and to make sure that you protect it. So, for example, our project, we actually incorporated into the contract that they will continue to update it for 3 years afterwards. However, then they got bought out by somebody who is now not honoring that contract, because they said it was these people who did it, and now we have nothing to do with them. So I think you have to take all these things into account. And so now who's going to give us the money for that, and commission, or who's responsible for it? And also just make sure that you have the rights to intellectual property so that you can do whatever you want with it. And I think most of these projects, it does have that embedded. And then in terms of getting, maintaining usability, I will tell you after these projects finish, but maybe you guys can tell us how you do that, because your project is more ahead than ours.
Thank you, Wendy.
Yeah, but certainly I will second what you said about follow-up funding. I mean, probably Tom can also support me on that, because we had this discussion back in Madrid about how to sustain our projects beyond. I mean, even cluster, we try to find ways of how to engage the projects that are in the cluster, because most of the projects are now at their end phase. Yeah. So how we move on with the cluster, right? So that's also the initiative about business acumen that you mentioned, right?
This is correct, Antonius, and I mean, I'm pleased to say we have a website coming out for the cluster itself. It should be available next week, which gives us more visibility and output. But because 11 projects will end over this year, the cluster itself would not die. The individual members within the individual projects will continue to engage, because the knowledge sharing experience that we have is going to be ongoing, and we're going to carry it. It's undoubtedly we're going to carry it for some time, but we will look for funding to do it. And there's a scheme like the EITH initiative, and what they do is they've set up a call where they invite proposals to come to them, and on that basis, those who are successful are funded a third by themselves, a third by the national associated, such as in Ireland, Enterprise Ireland, and then a third by those who are promoting as well. So there are schemes out there to help bring it closer to the marketplace as well. We're going to capitalize on that. Likewise, as I said earlier on from the beginning, we're bringing in business acumen people into the group now, and they will be like a bubble existing, who then will contact the projects and have a one-to-one basis with them on going forward to see, are they interested, or what changes are needed. They may be minor, they may be significant, to help them want to kind of invest and take it to another step. So we are doing what I call intelligent steps along the way to bridge that gap, because clearly we're all probably at the end of a project TRL 5, but we need to get to step 7 and so forth. So there are initiatives ongoing within the cluster to make it go, and it's no longer dedicated to 11 projects. Well, by the end of the year, it will not be 11 projects. It will be the individual members within the project will be part of the cluster going forward, and they can go to other projects as well. It's all part of the thinking that's going on at the moment. Hope that helps.
And the challenge here is that, as Panos mentioned, we are not really at the stage where we have a mature technology, most of the projects. So we are talking about TRL 5 or 6, which means that studies that we are performing are proof of concept studies. They cannot be considered as clinically validated tools or technologies. So there needs to be some kind of follow-up funding. Otherwise, you stay at the level of just lab prototypes, let's say, that they are not really be in operational environments. So that's really crucial to have such kind of funding schemas in place.
If I may join the conversation again, I absolutely agree with what you're saying. The funding is critical, because how you go about it, I think, is part of the issue as well. So this is why I suggested we've set up the EI Health and get collaboration with these people going forward. But to leave it, our incredible work that we've done in the lab will be and the justice, very much so for those who, like myself, have cancer, in this case twice the stage. We want the solutions to get to the marketplace. So over the course of the coming year that we're going to be doing within the cluster, we will be engaging a lot more with those who understand the business need, and they will then be becoming like semi-drivers to how we're going to go forward. They will become an integral part of the cluster, and likewise, when new projects come forward into the cluster, they will be engaging from an early stage and telling from the business point of view what is the key issue they have to address, and therefore we will be in stronger position to make sure that our solutions are closer to the market by the time they're finished, and they may want to directly invest. So it's been driven in that from that perspective as well. It's not just from the lab view. It's definitely targeting from maybe TRL 5, but they will invest to bring it to a higher level. So that integration process is ongoing at the moment as I speak. And I had our first meeting with a business acumen late last night in Cork, and they're fully behind with the initiative as well. We're going to bridge it any way we possibly can, and that's part of the solution going forward.
Thanks, Tom.
You're welcome.
Well, thank you very much for sharing all these interesting insights. We definitely shall continue the conversation in also other events. Hopefully, we will have this opportunity very soon. In order to conclude today's event, because 2 hours passed very, very quickly, unfortunately, MEP Lucas Furlas could not make it to be here with us today and address the final remarks. He had a flight change. So, well, the conclusions, I will have to address the final remarks. So, well, first of all, thank you very much to MEP Stelios Kimpouropoulos for the collaboration with ECPC and the LifeChamps group, and also to his team, especially to Georgios for their support in organizing this event. I would also like to thank a big thank you to the speakers for their valuable contribution, and to all of you for joining today. I wish you a great evening ahead, and goodbye from the European Parliament.
Thank you very much.
Thank you.
Goodbye.
Thank you.
Goodbye. Thank you very much. Okay.
Don't forget to stop the recording and download it, please. Just be interesting, we were 45, 26 people online, 17 here, and